All right, let's jump right in. We're going to take a high-speed tour of the cardiovascular emergencies that can kill a patient right before your eyes. Think of this as your high-yield guide to spotting these killers when, every single second counts.
So picture this scene, because you're definitely going to face it. A patient gets wheeled in, they're clutching their chest, their vitals are heading south fast. The clock is ticking, loud. Being able to figure out what's going on, to spot the killer, that's not just some academic quiz, that's the job.
Okay, so let's dive into it. Here's our game plan. We're going to unmask 5 major cardiovascular killers. Each one has its own signature, its own pitfalls, and its own critical moves you have to make. Let's start with the first one.
We're going to kick things off with the ultimate masquerader, the aortic catastrophe. An aortic dissection is, it's famous for looking like 100 other things, but it's absolutely brutal, completely unforgiving if you miss it.
This is the phrase every single one of us learns in medical school, right? It's the classic textbook definition. The thing is, in the real world, our patients rarely show up having read that textbook. Their symptoms can be way more subtle, way more confusing.
So let's look past that classic tearing pain for a second. Syncope. That's not just a simple faint. No way. It's a massive, flashing red light for something awful like pericardial tamponade. And that blood pressure difference between the arms, yeah, we all learn it, but it's only there in a minority of cases. And you have to remember this. A normal chest x-ray can make you feel better, but it can be totally misleading. Your clinical suspicion here is everything.
And you want to know why they move so fast? Look at this. The stakes just could not be higher. A mortality rate of 1 to 3% per hour. That's just staggering to think about. From the second that tear happens, a bomb is ticking. This is easily one of the most time-sensitive emergencies in all of medicine. So the number one priority is simple. Stop the tear from getting worse. Period. See, every single heartbeat is like a hammer, pushing more blood into that rip, extending the damage. So the team's first move is to lower the force of that hammer. They have to get both the heart rate and the blood pressure down, and they have to do it right now. And this is the weapon of choice, labetalol. It's pretty much the perfect drug for this situation because it does 2 critical things at once. It lowers the blood pressure, obviously, but it also lowers the heart rate. And that second part is absolutely crucial. You see, other blood pressure meds might cause the heart to speed up to compensate, which would just put more stress on that tear. Labetalol prevents that. It's the whole package.
Okay, so we just talked about a major plumbing problem. Now, let's switch gears to an electrical one. When the heart's wiring just goes completely haywire, your entire game plan, everything you do, comes down to the answer to one single question.
This right here, this is the fork in the road. It's the crucial decision point. Every single move you make next, whether you reach for a drug or you reach for the defibrillator paddles, it all flows from this one assessment.
And let's be really clear about what unstable actually means. It's not some vague feeling. It means the bad rhythm is causing dangerous problems for their vital organs. If you see altered mental status, if their blood pressure's in the tank, if they're having ischemic chest pain, that patient needs electricity, not just a drip. You got to move now.
When a patient is unstable because of a fast rhythm, this is often the answer: electricity. We're talking about synchronized cardioversion. Now, the synchronized part is absolutely key. The machine intelligently watches the patient's heartbeat and delivers a controlled shock at the exact right millisecond. It's designed to avoid making things worse. Think of it as a hard reboot for the heart's electrical system. And the decision tree here really comes down to one critical question. Is the patient stable? If they're unstable, their blood pressure's in the tank, they're barely conscious, the choice is electricity. You go for cardioversion. But if they're stable, their pressure's okay, they're talking to you, then you have a little more time to play with. You can try medications first to try and slow that rate down chemically.
Now, let's pivot to the most common killer on our list: Acute Coronary Syndrome, or ACS. Honestly, the best way to wrap your head around ACS is to just think of it as a fundamental crisis of supply and demand.
This definition really gets to the heart of the matter. It doesn't matter if it's a ruptured plaque blocking things up or just severely narrowed arteries. The result is always the same. The heart muscle is literally starving for oxygen. And that starvation, that's what causes the pain, the ECG changes, and ultimately the damage.
Okay, listen up, because this is so important for anyone in acute care.
The big pearl is that a heart attack is a master of disguise. Seriously, a patient can have a completely normal ECG and still be having an MI. They can have tenderness when you press on their chest. But the biggest pitfall, the one we see all the time, is blaming the pain on acid reflux. That burning pain could be cardiac. Pain that gets better with antacids could still be cardiac. You just cannot fall into this trap.
When this happens, a well-rehearsed drill kicks into gear, and it all happens in a blur. An ECG gets slapped on immediately to see what kind of heart attack we're dealing with. At the same time, the patient's getting oxygen, aspirin to help stop the clot from growing, nitroglycerin to try and open up those blood vessels, and maybe morphine for the pain. But the single most important step? Picking up the phone and activating the cardiac cath lab team. And this number, 90 minutes, is everything. It's what's known as the door to balloon time. That's the goal for getting the patient from the hospital door to the cath lab, where a cardiologist can thread a catheter up and inflate a tiny balloon to open that blocked artery. It is a frantic race against the clock, because time is muscle. Every minute that goes by, more of the heart muscle dies, forever.
So what happens when the pump itself just starts to fail, catastrophically? Well, you get a patient in acute heart failure who is quite literally drowning in their own fluids as their lungs just fill up. When you see this, you're seeing a late and really bad sign of severe pulmonary edema. This patient is in big trouble. Your job is to recognize that crashing pump and jump in long before it ever gets to this point.
An O2 sat of 82% on the monitor, that's a siren going off. It's not just a number. It's a sign that the lungs are completely waterlogged, that patient is getting tired, their breathing is unsustainable, and they are right on the edge of respiratory arrest. You have minutes, not hours, to turn this whole thing around.
Your goals here are pretty simple, and you have to do them all at once. You got to get the fluid off with diuretics. That reduces the preload. You need to make it easier for the heart to pump, so you use vasodilators to reduce afterload, and most important, you have to support their breathing. Non-invasive ventilation like BiPAP is your absolute best friend here. It can pop open those fluid-filled alveoli, and a lot of the time, keep you from having to intubate.
So, the strategy here is a three-pronged attack. First, you hit them with diuretics to help the body get rid of all that excess fluid. Second, you give them vasodilators, like nitroglycerin, which open up the blood vessels all over the body. This makes it easier for the weak heart to pump against less resistance. And finally, if that's still not enough, you can use drugs called inotropes to directly give the heart's pumping action an extra squeeze.
And finally, let's talk about the pressure cooker. We're not just talking about a high number on the blood pressure cuff. We're talking about pressure that is so intense, it starts to actively destroy organs from the inside out. Here's the key difference you have to understand. A hypertensive emergency isn't just about the number. It's the super high blood pressure plus evidence that it's causing acute ongoing damage to organs. Think a stroke, a heart attack, kidney failure.
And this difference sends you down two totally different paths. With an urgency, you've got time. You can use oral meds and bring the pressure down slowly. But in an emergency, the house is on fire. You need IV meds right now and an ICU bed because the biggest danger is not dropping that pressure fast enough to stop the organ damage.
The trick here isn't just to lower the pressure. In fact, lowering it too fast can be dangerous. The goal is a controlled reduction, and the choice of drug really matters. You have to tailor the medicine to the specific problem. We already saw the betalol, which is great for an aortic dissection. Nicardipine is a solid, predictable, all-around choice. And then you have something specific like enalapriliprit for a very particular condition. It's all about picking the right tool for that exact job. So let's wrap this all up in a nutshell. For a dissection, you have to slam the brakes on the heart's force. For a heart attack, it's a race to the cath lab because time is muscle. For heart failure, it's all about getting fluid off and making the pump's job easier. For wild rhythm, the big question is stability. That determines shock versus drugs. And for a pressure crisis, it's about a controlled, careful descent with the right medication. You know, these teams train for years and years to make these kinds of incredibly complex calls in just a matter of seconds, with everything on the line. Looking back at these scenarios, what's the one decision, the one split-second call that stood out to you the most? Thanks for joining me.